Okay, so let's move on to the next sessions. Our next presenter will be Dr. Guala Gao. I don't know, sorry if I pronounce it wrong. Dr. Guala, he is the neurointerventional radiologist that works in Odense University Hospital in Denmark. He is also a remarkable and talented neuroradiologist. Today, he will give us talk about his experience about endovascular treatment in basilar aneurysm. Please welcome Dr. Guala Gao.
Dr. Gao, is your audio okay? I don't think your audio is on, Dr. Gao.
Do you unmute him yet?
Yeah, he has to unmute himself. Okay, I'm unmuting him. Dr. Gao, you have to unmute yourself.
Yes, I do.
There you go. There you go. Perfect.
So I apologize.
University Hospital.
This was a technical challenge for me, and thank you very much, Luis, for inviting me to this meeting. I just want to tell you that I couldn't listen to Juha's presentation because I had to finish a case, but I listened to René's presentation, and I just want to tell that this was a very good presentation, and he's so good that he can afford to just show his complications, because everybody will understand that he has such difficult cases that even a complication we can learn a lot. We can actually learn most of the complications. So I have to start with two confessions, because I had two misunderstandings. The one is that we should concentrate on basilar tip aneurysms, and the second one that we should speak about 15 minutes. So I have a talk about 15 minutes about basilar tip aneurysms, but please accept these apologies because I didn't understand the point. So let's see if I go forward. I just start with a very quick historical background, because everything that we do now was made possible of these people who started the endovascular treatment of aneurysms. And the first one was Serbinenko. He put balloons in 1973 in the cerebral vessels. And then Guglielmi, who developed his coils, the detachable coils, and also Jacques Moret, who introduced the remodeling technique. And then came the intracranial stenting, double stenting, flow diverters that René mentioned. And nowadays we have also 3D coils, we have the web, contour, and Neqstent. So I will not talk about these ancient techniques, and I will not talk about the web, because I don't use the web, I don't trust the web, but I will give you a short talk about the other devices. And this is the very first case that I had the chance to see 2010. And this patient had a subarachnoid hemorrhage 2003. It was a left MC aneurysm that was ruptured and it was clipped. At that time already, they knew about the basilar aneurysm, but they could not treat it. It was in Denmark. They judged that it was too difficult because the aneurysm was wide-neck. So they referred the patient to Jacques, and he treated the patient 2004. So this is a 6 years follow-up, 2010. And what you can see, if you see the shape of the remnant, I think that Jacques used his double balloon technique, and he made, I guess, a very good packing of the aneurysm. But during the 6 years, the aneurysm, the sac was growing, and now the patient has a huge recurrence. And since she bled before, this is a dangerous situation. So we have to treat. So what can we do? Now, this is the question, and this is the 3D reconstructed image. As you see, the neck is very wide, incorporating the orifice of the right PCA and also a little bit of the left one. And also the shape of the remnant is so that it cannot contain coils, so that we can occlude without a supporting device at the neck. And since Jacques, who developed the remodeling technique, he already treated the patient with 2 balloons, I felt that it would be stupid idea to try to copy his treatment, because it will not give us a long-standing good result. So I decided to try to place double stents, the right PCA bacillary and also the left. And this is the working projection. You see, it was not very difficult to get in the right and place a stent. And at that time, the stents were not very visible like now. We just only saw the distal and the proximal markers of the stents. And then after the first stent, I put a delivery microcatheter in the aneurysm sac and put another stent in the left PCA and bacillary. You see, the other stent was another type, and we cannot see anything of the stent because they were not visible at that time. And after that, having secured the neck, I placed coils in the sac and achieved this packing density, and I was happy with that. And since Juha mentioned, I listened to his last minutes that all these aneurysms with stents and coils, they will recur. I am very happy to show this is the final final angiogram, and I have 5 years follow-up. And I don't see any sign of recurrences. I see a very stable aneurysm, and I think this is a good angiographic and clinical result. The patient had additional 2 small aneurysms, and after this, she wanted to get them treated also, so I did it also. So now she is done for all her aneurysms. You have also mentioned giant aneurysms, how to treat them. And I got in the same year, this one, the lady who reported brainstem symptoms, and this diagnostic workup revealed a huge, giant, partially thrombosed aneurysm at the bacillary tip. And you can see this is the axial image. The aneurysm was very big. The transverse diameter was over 20 millimeter, and the longitudinal diameter was 35. So I said, we can call it giant. You see here, this is the filling portion of the aneurysm, and this is a thrombose portion. This is also a challenging case, and I think this is very difficult for a surgeon to get rid of this aneurysm. To explain the brainstem symptoms, you can see the aneurysm in the middle compressing the brainstem all around, and the contrast enhancement in the wall and around the tissue. So there was an inflammatory change in the brainstem. So she was neurologically impaired. This is the angiographic image of the aneurysm injecting the left vertebral. What you see here is that both PCAs are very small. And if you see the 3D reconstructed image, it is also obvious that it's very difficult to get into the right one because there is no direct access. And if we do Y stenting, we always have to go to the more difficult one first, because then we have to cross the stent with another microcatheter to go to the left. So I had to get into this one, and it was very, very difficult. You see the sizes. This is the lung. It is 20 millimeter long here and very wide also. So what I did finally, after 1.5 hours fight, that I could very carefully navigate the microcatheter and the microwire into the aneurysm sac. You see here the microcatheter getting a big loop and coming out to the right PCA, and placed the stent first into the right, after to the left. See here also the stent marker. And similarly to the previous case, here you see the both stents in the PCAs and in the bacillary. I could achieve this packing density. Again, very good flow in all the branches afterwards, and all the perforating are open, since endovascular surgeons don't touch the perforators. We don't occlude the perforators. This is the final angiogram. Everything is open. You see here the small perforating branches. And in this case, I have 1 year follow-up, because this patient clinically recovered very well, and we didn't see any reason to do a longer follow-up when the clinical symptoms are gone. All the branches are open here also, and you see the MR, there is no edema in the surrounding brainstem. It is getting smaller. But now I got the idea that I will get in touch with this patient and ask her for a new MR, because now after 8 years, I would like to see if the lower portion that was filled with thrombus, if it gets shrunken. So I hope it will, but I cannot show anything now. So after these two old cases, I will show you a couple of cases that are treated with some new devices that are developed recently. And one of them is the Neqstent. It's a braided nitinol mesh disc. We place it inside the aneurysm at the neck to support the coils. Nowadays, it is delivered via a 0.027 microcatheter, and it has a mesh that permits a second microcatheter to pass through or around its mesh, and then we can deliver the coils through this. This is retrievable and repositionable, and we can electrolytically detach upon the completed treatment. Sizes are 7, 9, 11 millimeter, and the 40 millimeter is coming soon. Additionally, the microcatheter sizing will go down to 21. So these will be able to place through the 21, which is a small microcatheter, and only the biggest one, the 40 millimeter, in the 27 microcatheter. So this is how it looks like. You see the mesh. It is gathered together with an assembly point here, and this is where you can detach. This is the pusher wire, and this is how you can cross it with the microcatheter and the wire, and to deploy the coils. So the idea is that it will stay in the sac, and no, we don't leave any metal in the parent artery. So this is the very first case treated 3.5 years ago. Patient was earlier operated on, and she had several aneurysms, one of them the basilar tip. And this was also wide-necked aneurysm. The neck was 9 millimeter, incorporating the orifice of the right PCA, a little bit also the left. So for us endovascular therapists, it's very easy to access the basilar tip aneurysm, because the basilar artery usually not a challenge. So it's very easy to go with the 27 microcatheter and deploy the stent, the Neqstent. You can see here frontal lateral view. You see the shape of this device. And since this was my very first case, I went through the device with the delivery microcatheter. It was not very easy. So after that, I changed my strategy, and I put the small microcatheter first, which is very easy, and then place the device afterwards. So what you see here is that this is the tip of the delivery microcatheter, and then after that you push coils and you fill the whole aneurysm with coils. And this is when the Neqstent is detached. You see the distance between the stent and the pusher wire. It is a 5 seconds detachment time. And this is the final angiogram. You see all the branches are open, the aneurysm is packed, and I have an early follow-up on this patient after 5 months. You see the shape of the coil package is the same, and the aneurysm is totally occluded. And additionally, the right P1 segment is also occluded. Is it a problem? No, I don't think so. On the contrary, this is a benefit, because it means that the whole aneurysm is totally occluded, and the right PCA will fill through the fetal orifice from the carotid. So we got the best possible treatment result because this aneurysm will never recur. So this was my very first case. And after that, I treated additionally cases like this one. This was a 55-year-old lady. She was sick. She had a pulmonary cancer. And they performed an MR to see if she had metastatic lesions in the brain and found this huge aneurysm. And even if she had a limited lifetime, we decided to offer her that she could live as long as she could manage with another disease. And we offered her the treatment. And this is the aneurysm. You see that the neck is a little bit oblique. It makes it a little bit more challenging than the straight one. The aneurysm is big. It's 16 millimeter long and 12 millimeter wide, but it doesn't make a big difference. If we can control the neck, we can treat the aneurysm. So here I place the small delivery microcatheter first and the bigger one afterwards. Deploy the stent at the neck. And it's a little bit difficult to see, but it's there. And what is interesting is that this device has significant flow diverter effect. So you see here, the flow is getting down in the sac while all the other branches are well flown. It is due to the flow diverter, intrinsic flow diverter effect of the device. It explains why the follow-up results are always better than when we finish the treatment, because the coils and the device work together. So this is the late, it's a late capillary early venous phase. You see the stagnation in the sac. And this is the first coil. Then we follow and pack the whole aneurysm. And what is interesting, after the first coil, the stagnation is even more significant. And this is what I want to show you, very interesting. This is the last coil. This is a small one, 2x8 coil. The interesting is that this coil is not distal to the Neqstent, because this portion of the aneurysm could not be covered by the Neqstent due to the shape of the aneurysm. So, but it is possible to fill this portion outside the Neqstent, because the Neqstent will help to keep the coil in place. So this, I was very happy, and since the technique allows us to show the last coil, I thought that it is interesting for you to see also. So this is the final angiogram. You see all the branches are open. I treated this patient in the spring, and she lived additional 6 months. She was close to do a follow-up, but we didn't want to press her. So she passed away due to his pulmonary cancer. So I will not be able to show you any follow-up on this one. So when we had this initial success, then the company gave some information to the neurosurgical community about this device. And this is a case from Canada, Edmonton. This was a huge recurrence of a basilar aneurysm, basilar tip aneurysm that was treated long ago. I don't know the exact time of treatment, and the patient was lost for follow-up. What you see here, the aneurysm is widely open, and again, this is an imminent risk for subarachnoid hemorrhage. So I got the images. First, I got these images on my phone, asking if I thought it would be possible to treat this with Neqstent. And the only thing I could see is that both PCAs were very small, tiny. The neck was not extremely wide, but the aneurysm was very wide. It is impossible to do it without a supporting device at the neck. So I thought it could be done. If we placed an 11 Neqstent here, I thought it could be done. So we scheduled the treatment, and I traveled to Edmonton. And then we, having the lessons from the previous cases, we put the delivery catheter deep in and packed the distal portion of the aneurysm first with coils, then placed the Neqstent, what you see here at the neck, and then we could achieve this perfect packing density of the whole sac. And this is the final angiogram. And we have 9-month follow-up of the case, which shows still good result. These are the PCA orifices, so this is not a recurrence at the neck. So I think this is also a very good result. So I talked about the Neqstent, which is here. The same company, the Series Endovascular, has another device, which is called Contour. And the difference between these two is that the wires in the Contour are thinner. We can see, and you see, this is much tighter mesh. So the wire mesh is much tighter. So this device can occlude the aneurysm on its own. While here we have to go through and put coils. So this is a short overview. So the Contour has 144 wires, while the Neqstent 64, and the metal surface area is bigger here. These are the same size devices. So this would be capable to occlude the aneurysm on its own. So see how it works. This is the very first case. This was a patient after subarachnoid hemorrhage treated in another institution, and the follow-up showed significant neck remnant. So when you see the shape of the aneurysm, you will realize that it is very, very difficult to offer any conventional treatment option for this patient. And finally, we realized that the Contour would be the best treatment option for her because of the sizes of the vessel. So this is the basilar artery, which is very narrow. This is the original angiogram. This is the 3D reconstructed image. And this is the treatment result in the other institution with somewhat loose packing here at the neck, and not a big surprise that follow-up at 9 months showed significant remnant. So what to do here? As you see here, all the sizes are very, very small. So here it's very difficult to place several devices here. So what we saw that if we can get in with the 027 microcatheter in the sac and place the Contour here, probably it could achieve the results what we want. See here the size of the 27 microcatheter. Going through this small portion, it would not allow any other device, any other microcatheter. So this is the Contour, this is the smallest Contour placed in place. Contour detached. Final angiogram, the flow in the sac is still the same, and follow up at 7 months. See here that the open portion of the aneurysm is much smaller, and actually the Contour device is here, and this portion is necessary to feed. This is a superior cerebellar artery. This is not a PCA. So this is a good result again, and this can be even better with longer follow-up, which I will show you in the next case. This is a 64-year-old female with a quite big basilar tip aneurysm that we decided to treat with the Contour device. And you see here the sizes. The neck was 7 millimeter in this projection, the frontal projection, but in the lateral projection, it's much bigger because we don't see there was a portion of the aneurysm here in the frontal. It is not filled here on the 3D image, but it is filled on the ordinary angiogram. So you see here that the neck was much bigger than that what the company gives, like a largest diameter, or 8.5. And they were not happy to treat this patient because they were not convinced that the device could cover the neck and could get good results. And what I told them that please give it a chance. And then they agreed. So what we did, we placed the biggest Contour, 11 millimeter in the sac. And then this is the immediate angiogram afterwards. And we waited 25 minutes. the 25 minutes showed that the device, the position of the device was stable. There was stagnation in the sac. You see here slow flow. This is late arterial phase, and detach the device. Took back the patient 7 months after. It was still not occluded, but analyzing the angiogram, we can see that the flow diverter function, it works. So the inflow is much slower and the stagnation is much more than it was in the beginning. This is the lateral image, the same. So I was not very happy, but I said, probably it can get better. And the problem with this patient was also that she was still on double platelet inhibition. So this is the next follow-up at 18 months. And what you see here is that there is hardly any inflow, probably very small at the base. This very small portion of the aneurysm is outside the contour. So everything that is distal to the contour, it's occluded. So it's very good result. And we have also the 3D reconstructed image that show that this small portion that is visible also here, this is outside the device. So I think this is the last case that I will show you. It's a very difficult aneurysm. It's a relatively young male. He had multiple strokes from the posterior circulation, and the MRI showed this aneurysm, which is the 3D reconstructed image shows that the neck is extremely wide.
Gula, no, I don't have too much time.
Okay, so let's show just, I put the device, the contour,
Yes,
put some poise. This is the final angiogram, and I'm done. Thank you.